to Fit for You, the show that teaches you how to live a healthier and more fit lifestyle. We're tackling a very interesting subject today in a little different format. If you noticed, I'm wearing my pajamas with my little Salvatore dachshunds on them, I might add. But I'm wearing pajamas because today we're going to talk about sleep. Dr. Michael Lileas, one of our area's finest, one of our nation's finest physicians, is joining us and just received his board certification in sleep. He's taking it to a whole nother level. And as you know, sleep is a really important component of a healthy and fit lifestyle. I don't want to waste too much more time because I want to get to Dr. Lileas and all he has to say. Welcome to Fit for You. My dear friend and one of our country's finest doctors, Dr. Michael Lileas, is joining us today to talk about sleep. Let me do your intro so we do this right.
Sure.
He didn't have enough credentials after his name, so now we've added board certification in sleep. But prior to, board certified doctor of internal medicine, founding partner of Salem Internal Medicine, former associate professor of internal medicine at Neo-UConn, the hospitalist at the surgical hospital at Southwoods currently, and now a board certified sleep internal medicine physician, correct?
Correct.
And let me read this and then I'm going to turn it over to you. Why does this make you special? Because this is a very rare certification in the medical field. I mean, very few people have this, so it's quite an honor. Specialty designed to encompass a multidisciplinary body of knowledge regarding the anatomy, physiology, biochemistry, pathophysiology, and pharmacology of sleep and wakefulness and their disorders. By the way, I had to prep, as you know. Dr. Lileas and I had to prep on pronunciation of words so I can make sure I don't mispronounce things. So tell us, what's special about being board certified?
Well, just that introduction makes it sound so special.
Oh, it does.
Which really it is, because sleep medicine is its own specialty, and it's only been in the last several years that people have been going into sleep medicine, and they're becoming more and more certified. Before, it used to be a specialty of just pulmonologists or lung specialists, and now that it's a specialty that you can get into from internal medicine, pulmonology. Some anesthesiologists get involved with it. Psychiatrists can actually get involved with it, and the otolaryngologists, the ear, nose, and throat doctors. But it's a very difficult way to get certified, is to go through what they call the grandfather clause, which actually stopped as of last year's boards. But what it is you can get into the specialty by passing the certification exam and knowing all of the things that you read about in that text.
And don't you have to practice for a certain period of time or focus on this?
You also have to practice, I believe it's at least 5 years, and you have to have read certain amounts of sleep studies and what they call MSLTs and MWTs. They're all different types of studies that we use in the practice of sleep medicine. So all those have to be done, and you have to have at least 5 years in the field in order to obtain your certification.
What we've discussed on prior shows, and this really is becoming a key point of not just medicine, but fitness and health. We're finding out that if you can manage your stress, you need to start there before you can get in good physical condition, and sleep is such a key part of managing stress.
Absolutely, and I really think that there's more and more focus on sleep medicine and sleep disorders in this day and age. Even President Obama had one of the things I read about was some of the initiatives were to put more focus on sleep, and obstructive sleep apnea is the big one that people always talk about. As soon as they think about sleep medicine, they think about obstructive sleep apnea, where you have to have the CPAP and wear the mask at night. But there's so much more to the specialty, which is kind of why I wanted to go through some of this before we get into the obstructive sleep apnea.
And you put together an outstanding outline. I want to make sure we touch on a lot of the points. I doubt we're going to get through it all, but it's fabulous. Normal sleep. Talk to us a little bit about what's normal sleep.
Basically, sleep is divided into various stages. Back when sleep medicine was first starting, they divided sleep into 4 stages, plus REM sleep, which is your rapid eye movement sleep. Sort of your dreaming sleep, where you rest. It's a very restful sleep.
And I have one quick question, because when we were preparing, your eyeballs, as you told me, which I never realized in REM sleep, are really like moving back and forth, aren't they?
Absolutely. And I should have brought you an example of a sleep study showing the rapid eye movement that occurs during that stage of sleep, because the rest of your muscles are like this. None of your other muscles move, just your eye muscles. Now, there are certain disorders where the rest of your body can move, but for the most part, when you're in REM sleep, nothing moves except your eyeballs, and you breathe.
I just think that's so cool.
But anyway, REM sleep is about 25% of your sleep. The non-REM sleep, which is divided into the other 3 stages, is the rest of it. And I believe that during this we'll have a hypnogram, which is an example of the various sleep stages and how we see it when someone has a sleep study. It'll show us what types of sleep stages they went into, because you may not go into every sleep stage at every point in time during your night of sleep. You may start out going to stage 1, then go into stage 2, stage 3, then maybe go into REM. That's the usual. And then that pattern repeats itself 4 or 5 times during the night. During your REM sleep, usually your REM sleep, as the night gets longer, gets a little bit longer, until you get to right before you wake up, then your REM sleep is often very short.
Can I go through an evening of sleep and never get into my REM stage?
Absolutely.
And I found it most interesting also when you told me you can get in your REM stage and then you can be woken up by something and you have to start this process all over again. You just don't fall back into REM.
Right. Unless you have a certain disorder. Then certain disorders, actually, certain people can go right into REM sleep. They start and they fall asleep and they're right into REM sleep within a minute. But that's a kind of a more rare disorder that happens. But most of us follow a little pattern where we get into REM sleep. It's the last of our stages, and then it starts over again. Something wakes you up during the night, then you go back into stage 1, and then you go back into stage 2 and stage 3, which is often called your slow wave or delta sleep, which is also a very restful sleep.
Let's talk about medications a little bit, because a lot of people are taking, let's start with the antidepressants and then let's talk about some of the sleep medicines. But the antidepressants, what's their effect on this?
Tons of antidepressants on the market, whether they're what we call the SSRIs, the serotonin reuptake inhibitors. Those are the most common. That's your Prozac, your Paxil, and those types of medication. There are also what they call the tricyclic antidepressants. And those are the older antidepressants that we used to use, but some people still use them because they sedate people. But they do one other thing also. They suppress REM sleep. So people who are taking certain antidepressants can have, instead of having 3 or 4 episodes of REM sleep during the night, they may have 1 or 2, or may have none. I've read sleep studies where we have no REM sleep whatsoever. And basically they have no other problems except they're on an SSRI. So what I'll recommend oftentimes to the referring physician is, if we can get them off this antidepressant for 3 or 4 weeks and repeat the study. Because we really want to see them go into REM sleep. We want to see how much they go into REM sleep. And especially if we end up titrating CPAP on someone, we want to see them go into REM sleep.
Now, once you diagnose them, can you effectively help them to sleep better while they go, if they have to go back on their antidepressant?
Generally, we can. Unfortunately, there are some people who perhaps need this antidepressant more than they need to get into REM sleep. And unfortunately, that sometimes happens. But oftentimes what we'll do, if we have to keep someone on an antidepressant, the SSRI, I'll recommend repeat the study in 6 months to a year and see if, because they're now on CPAP and they're able to sleep better, do they get more REM sleep?
Let's talk a little bit about sleep medications, because I found it very interesting that sleeping pills sometimes don't work. One of the reasons being, you may be the type of person, and then we're going to get into this more, I think, when we talk about insomnia, or you can cover it now.
Okay.
But people think sometimes they're taking a sleeping pill to go to sleep and that's not working, when the problem isn't they can fall asleep, they can't stay asleep.
Right. And I think, that's a big approach that sleep medicine specialists have over the general internist, the family practice, the pediatrician. Someone comes in you and says, "Hey, I can't sleep." Some people leave it at that. It's like, "Okay, you can't sleep. Here, try this Ambien. It's a sleeping pill. We're gonna see if we can get you to sleep." Mm-hmm. But then, when you really delve into what the problem is, and by delving into the problem, what I mean is you have to give someone a sleep diary. Mm-hmm. You have to say, "Okay, are they really sleeping or not?" And a sleep diary will help you know that.
And what is a sleep diary?
All they do is record. They tell us, "Okay, it's 10 o'clock at night, I'm going to bed. I didn't fall asleep, it's 1 o'clock in the morning, I'm still awake." So it's...
Do you want to know things, is the television on? Are the lights out?
Absolutely. That
What
all
are you
has to do
wearing?
with sleep hygiene. Sleep hygiene means, look, when you go to bed, you should do one of two things. Go to sleep or have sex. Mm-hmm. That's what the bedroom's for. That's what the bed's for. If you go to bed and you put the TV on, that ambient light from the TV sometimes is enough to suppress your melatonin, which is the hormone of darkness, and helps you to sleep. So sometimes just that light from the TV, the light from the iPad, the light from the iPhone, sometimes that is enough to suppress some of your melatonin, and you can't sleep. So you got these lights blaring out at you, and you're like, "I'm really trying to sleep, I'm trying to sleep," and you can't. Those are things you write down in your sleep diary to tell us, this is what's happening. Well, then we know your problem is sleep hygiene. We're going to get rid of all this stuff. We're going to get rid of the TV. You're going to go to bed when you're tired and go to sleep. If you go to bed when you're tired, there's nothing wrong with your sleep hygiene, but you still can't sleep, then we recommend you get out of bed for 20 minutes, go do something else. Don't do it in your room. Don't read a book in your room, because then you're telling your mind it's okay to read the book in the room, I'm just going to do this. Go outside the room till you're tired. Come back in the room, go to sleep.
You talked a little bit about doctors referring to you. During your tenure of being a physician, and it's probably been very helpful, you were a doctor of internal medicine and a practicing physician, seeing patients on a regular basis. You do like working in concert now with the internist or the family doctor or the pediatrician, correct?
Correct.
It makes a nice team for you.
Absolutely. And we may have some other tools that maybe they don't have or don't think about. One of the things I think you and I talked about was actigraphy or actigraph. It looks like a wristwatch, and it monitors your motion. It can monitor light. You can get them that they monitor light and ambient temperature. But basically what it does is it allows us to see, this person will wear it for a week, at least a week. So it'll allow us to see when this person goes to bed, do they really fall asleep? Or are they just moving all night? Now, some people have, of course, restless leg and things like that you may see some tremor artifact. But for the most part, when you look at an actigraph, the results of an actigraph, it'll tell us when that person fell asleep, how long they were asleep for, and whether that motion was significant or not.
And a lot of these fitness bands now, like the Nike Up band, the Fitbit, there are different things. That's the same technology
Absolutely.
they use, right?
Yes, absolutely. Same thing.
If you think you're having problems, is it good to maybe start with that so you can, give that maybe to your doctor and you as a baseline?
You could, as long as they have a printout available as to here's what I did See, the actigraph, it'll print out on the computer, it'll print out exactly what you did and how you slept, for a week. And I don't know if the other bands do that or not.
And it's very important, when I am going to think about having a sleep study done, we talked a little bit about, what is the difference between doing it at home with something monitoring you as opposed to being in the lab. And shortly we're going to be joined by Sheila from the Delta Sleep Lab. But explain to us the difference and why it's important to really go to the lab and have this done, how it makes it so much easier and better for you to get the right diagnosis.
Well, first of all, the unfortunate problem is the governing bodies, such as the Medicare, Medicaid, and insurance companies, are telling us when we can and cannot do in-lab sleep studies. There are some people that the insurance companies absolutely refuse to have the sleep study done in lab because it's more expensive, obviously. But when we do someone in the sleep lab, we are able to tell you what stage they were in, whether they went through all the stages of sleep, whether they have restless leg or periodic limb movement disorder during sleep, whether they had some type of REM behavior disorder during their REM sleep, whether they had any type of significant arousals, and measuring their oxygen saturation during the night. Whereas when we do the study at home, all we can tell you is they may have sleep apnea. They may not. We can't tell any of those things. We can't even tell you if they actually went to sleep. We don't know that. We think they did. They wrote down in their little diary, we went to sleep, but we don't know that for sure. We can't tell you if they actually went to sleep. That's why I think in-lab studies out of lab studies should only be done if there's a low probability that that person has sleep apnea. If you say, well, I snore once in a while and I wake up pretty refreshed and I don't feel bad during the day, but I'm worried I might have sleep apnea. So you have a low probability that you have sleep apnea. You're thin, you're in good shape, your neck size is below 16 inches.
Yeah, that neck size was interesting to me. A woman you would like between?
Below 16 inches.
And a man?
Below 17 inches.
Okay.
Yeah, otherwise it's an increased risk factor for sleep apnea.
Okay. And just because I snore.
Does not mean you have sleep apnea.
What if I snore really badly?
30% of people snore.
Can I snore really badly and not have sleep apnea?
Yes.
Really?
Yes. 30% of people snore, only 4% have sleep apnea.
Interesting.
Yeah.
Okay.
Now, do we do sleep studies for people who snore? Absolutely. Especially if they come in with their spouse or bed partner and say, hey, I think she stopped breathing at night. We do it. Let's do it right then. But if I say to you, Mary, I really think you have a low probability that you have sleep apnea, I'm going to recommend they do a home study on you, because that's all we need.
But if I snore really loudly, maybe I don't have sleep apnea, but aren't there other things I may have that you can help me with or you can help to fix that problem?
Yes. And there, many times they may be a surgical problem. There may be something with your airway that needs to be looked into. Maybe most common thing is with the sinuses, and nasal polyps are often a cause of snoring. So there are things that we may say, let's send you to the ear, nose, and throat doctor and see what they say. Because what we see here, you don't have evidence of sleep apnea, and I think we can go ahead and get away without doing a sleep study or a home study.
One more thing I want to talk about, and then we'll call Sheila over, because
Okay.
I want to talk about the CPAP and the different masks and all the interesting things that go with that. Restless leg syndrome. What is restless leg syndrome? Does it mean I have a sleep problem?
No. Actually, restless leg is not a sleep problem. It is listed under movement disorders in the whole gamut of sleep medicine, but it's actually not a problem with sleep per se, but it can keep you from falling asleep. Restless leg usually occurs before you go to sleep. You're very tired at night, you're laying in bed, and all of a sudden your legs want to move. You just want to move your legs, and most people get to the point where they have to get out of bed and walk because their legs are just itching to move. And that is, the definite definition of restless leg syndrome. My legs want to move. Somebody comes in and says, my legs want to move so bad I have to get up and walk. And then I feel better. Then I go lay back down and it happens all over again. Those are the people that have restless leg syndrome. Now, that being said, I said it's not really a sleep disorder, but 80 to 88% of people who have restless leg also have what's called periodic limb movement disorder of sleep. In other words, when they fall asleep, if the restless leg, says, okay, you can go to sleep now, they still twitch their legs during the sleep. And you can ask the bed partner usually, oh yeah, they kick me all the time. Their legs are moving, jumping all over the place. They're not even aware of that. They're only aware of what kept them awake. So that was their complaint that they came in to see you was, I couldn't sleep. What do you mean you couldn't sleep? I couldn't fall asleep because the leg movement kept me from falling asleep.
Mm-hmm. This is one of the most interesting things in this whole scenario is two very different things. Being able to fall asleep and being able to stay asleep and get a good sound sleep.
Right.
Fascinating. Shall we have Sheila join us and we can get a little more in depth into some of these particulars about the CPAP and things like that?
Yes.
We now welcome to our panel Miss Sheila Slepski, and Sheila is the manager for Delta Centers for Sleep, a surgical hospital at Southwoods facility, offices in Boardman and Austintown, and you are also a respiratory therapist and sleep lab technician, right, Sheila?
Yes, I am.
We are so happy to have you. I was so excited
Thank
when
you.
Dr. Lileas recommended you join us because I think one of the big misconceptions is that the CPAP mask, which is such an important component to this whole process, is very difficult and cumbersome, and it's this huge thing, and you're going to show us that there are some options here.
Right.
Start with Dr. Lileas. What is the CPAP mask, and why is it important to this process?
Well, basically the CPAP mask is the continuous positive airway pressure that we use to help keep the airways open in someone who has obstructive sleep apnea. Basically, it allows them to be able to breathe and to allow them to stop or to not stop breathing like many of them do. Many people who have sleep apnea may stop anywhere from 5 to 30 times an hour.
And they literally stop breathing in their sleep,
Absolutely
right?
stop breathing, yes.
Okay.
And, oftentimes it's anywhere from 10 seconds to a minute. And then they wake themselves up. Or their spouse, if they're sleeping with someone else, their spouse may wake them up. Mm-hmm. But they hear that they're kind of struggling to breathe. And so the CPAP helps us to treat that underlying disorder.
Now, I'm going to turn it over to you and Sheila because I think this is such an important point in this show because I really want to take some time, show the different masks, and you told me fit is critical, correct?
Yes, absolutely.
The first step is getting the right mask for you with the right fit.
Right.
If it doesn't fit, what happens?
Well, we have trouble sometimes. I mean, there are people who, if you can't get their mask to fit right, and a perfect example is someone who comes in with a full beard. Mm-hmm. It may be very difficult to get them fit with a mask that's tight enough and it's not causing a leak from where the beard is. Oftentimes those people either have to put up with some leak from the mask, mm-hmm. or they oftentimes will go without it. And we may recommend, let's try something else, like a mandibular repositioning device that can hold the jaw forward so that it makes it easier for them. Those are some of the other things we haven't gotten into yet, but certainly the first line choice of everyone with sleep apnea is the CPAP mask.
So Sheila, tell us what you have.
Well, there are basically three styles of CPAP masks. There are nasal pillows that are like this one that fit right into the base of the nostrils. These are the most, the least invasive type of mask that we have. There's a small amount of surface area that we have to seal just around the base of the nostrils. So it makes it very nice for people who don't want a big mask on their face.
And do you want to demo, take it off, put
Sure.
it on so they
They're
can see how
very,
easy?
They're very easy to take off and put on. There's Velcro straps. You just slide it over your head. You put the prongs against the nostrils, and then if you need to adjust the Velcro, you just slip it off and slip it back on again to make it the tightness that you need it to be. So the nasal pillows are actually very nice, and we do use the nasal pillows. Dr. Lileas was speaking about a patient with a full beard. Since it's so hard to get a seal with a mask for a patient with a full beard, oftentimes we will recommend nasal pillows because you're bypassing all the hair along someone's face and just using the nostrils as the secure point there. So it works very nicely for someone that has facial hair. We'll try the nasal pillows.
Do you want to explain what you have it hooked up to and how this
Sure.
whole thing comes together?
Sure. So this is the mask. This is what we call the interface itself. It has to hook up by a hose to the actual CPAP
Does the
machine
hose come
itself.
off the mouthpiece?
The hose comes off of here, and this is the hose extension that comes directly to the CPAP machine itself.
Okay.
Basically, the CPAP machine is just a blower of air. There's no oxygen, there's no medication that's in here. It's just a blower of air. And we actually put distilled water in this as a humidifier so that the air that you're breathing in is moistened so that it doesn't cause any dryness or irritation of your throat.
Oh, that's interesting.
This particular model itself actually doubles as a alarm clock as well, so then you don't need more than one device sitting on your nightstand. They're making the machines smaller and smaller and more patient-friendly so that patients are more compliant and more willing to use their machines.
Now there's a little dial in the front. What does
This
that
is
do?
the dial that you press it to turn it on and off, and I don't have it plugged in right now, but you turn it on and you turn it off, and then you can adjust the alarm setting for your alarm clock. And you can also press it again, and then it can actually turn your pressure down until you fall asleep. It's called a ramp feature. And then as you fall asleep over a period of time, it actually adjusts the pressure and steps it back up again so that your therapeutic pressure is met.
So does it know, or is it set, or do you set it as the technician as to the maximum it should be based on my particular case?
Correct. Whenever you come into the sleep lab at night, and after you fall asleep and you start to have your respiratory events where you stop breathing or have shallow breathing, we actually will control the amount of pressure that is delivered through the CPAP machine and increase it as necessary to stop those respiratory events from occurring. So you might need a CPAP pressure of 6 centimeters of water pressure. I might need a CPAP pressure of 8 centimeters of water pressure. Dr. Lileas might need 10. So it's all an arbitrary setting as to every individual patient. So whenever they get home with the CPAP machine, after we've figured out what exact pressure that you need, the durable medical equipment company like Sealy Medical or Boardman Medical or Healthcare Solutions will provide you with the equipment, and they will have that setting that is your individual setting already programmed into the machine.
Now, once you do that, well, two questions. Can I get to a point where I may be able to eliminate this if I follow my procedures properly? Or once I start 9 out of 10 times, am I going to need this the rest of my life?
That's a really good question. And most people, or a big risk factor, I should say, for obstructive sleep apnea is obviously weight, obesity. And we often tell people if you lose a certain percentage of your body weight, and we usually like to go 10%. So if you're 300 pounds, you lose 10% or 30 pounds, we may repeat your sleep study. Oftentimes what we see is that we're able to go maybe from 10 centimeters of pressure down to 6. Mm-hmm. So maybe you don't need as much pressure. Are you able to get off it?
Now,
Probably not at that amount of weight loss.
All right,
now let's say one other thing. Let me say that maybe you had a gastric bypass, and maybe over the next year or so you lost 100 and some pounds. then I think you might be able to come off the CPAP.
Plus, you can lose 100 and some pounds without gastric bypass too. So all you need to do is lose 100 pounds.
I understand.
But my other question was: is it important too, not just to lose weight, but to improve my cardiovascular fitness level? So should I be doing something like walking or biking, or so that I'm improving?
Absolutely.
Okay.
Number one is obstructive sleep apnea is a risk factor for heart disease, high blood pressure, obesity itself, diabetes, and strokes.
Mm-hmm.
All those are increased risk to develop those if you have obstructive sleep apnea that's untreated. That's why it's so important to treat obstructive sleep apnea. I mean, do you ever hear about, talk about reading in the paper, you see someone dies and you says, yeah, that guy, he was fairly obese, I wonder what he died from. There's a good chance he died from sudden cardiac death because he had an untreated obstructive sleep apnea.
Mm-hmm.
So it's a very, very important thing. And people who go into the doctor and they have high blood pressure, they can't get their blood pressure controlled. It may be because they have underlying sleep apnea. Studies have shown if you treat the underlying sleep apnea, sometimes the blood pressure gets better. You may go from needing 3 medicines to 1 or maybe none.
Mm-hmm.
So it's really, really important with regards to hypertension, heart disease. Patients who have an irregular heart rhythm called atrial fibrillation, one of the most common arrhythmias that we see. Those people are often sent for what's called an ablation. They get this ablation which takes them from atrial fib back into sinus rhythm.
Mm-hmm.
And then if later on down the road they go back into atrial fibrillation, we oftentimes will get a consult to study them in the sleep lab and find out they have obstructive sleep apnea. That's why they can't get out of their atrial fibrillation, because of the sleep apnea. And the most important cardiac arrhythmias occur during REM sleep, which is why when we study people with CPAP, when we put them on CPAP, we want to see them get into REM sleep. Mm-hmm. And if they don't get into REM sleep because they're on an SSRI or some other medication, we can say, yeah, here's the pressure we think is going to be good for you, but we really want to see them get into REM sleep, because that's when a lot of arrhythmias, and that's when most of your sleep apneas occur.
And let's go to now, we have a couple of different masks. By the way, if I do wear it faithfully and I follow doctor's orders, I can wean myself down too. If I have to start with the big heavy mask, I can wean myself down to this nice smaller one, correct?
Well, we can always change masks. Sheila, how often does most insurance companies pay for change in equipment?
Most insurance companies will replace your mask and your tubing every 3 months to 6 months. There are a few carriers that make you wait a year, but those are few and far between. They actually want you to replace your equipment because after you wear it every night, there can be some breakdown, and then you would not be getting your therapeutic pressure. So the durable medical equipment companies are very efficient at making sure that they let their patients know when they're eligible for new equipment. So they're very good about that.
Now show us what we have here.
This is a nasal mask. This just covers the nostrils, it covers the nose. Some nasal masks actually have a forehead rest as well, but this particular model does not. This one's also very easy to get off and on. There's just little straps over here. You just push them in and take them off. And whenever you are the patient, you learn where your mask is. You learn how to snap it on very quickly. So if you would have to get up and use the restroom in the middle of the night, you don't have to adjust any Velcro straps because it would already be set for you. You just slip the mask off, go to the restroom. Whenever you come back in, slip it over your nostrils, and then snap it in on the side. So it literally only takes a few seconds for you to do that. And the masks nowadays are made from non-latex materials. They're generally some type of silicone. They're all hypoallergenic and able to be washed and disinfected quite easily by the patients.
Do you wash it every day, or do you have to wash it once a week? Or?
They usually recommend that you at least use a sanitary wipe, and most durable medical equipment companies even sell wipes that you can just wipe it off, or they recommend just using any type of antibacterial dish soap and letting it air dry, or they even sell CPAP equipment dryers for patients' homes, and they're usually right around $100 for the CPAP dryers.
When I am diagnosed to need a CPAP, is it a 7-night-a-week thing, or are there some times where you can get away with a night or two without?
What does the insurance company say about that, Sheila?
Well,
Talk about the smart card.
There are Medicare guidelines that most insurance companies wear, and the minimum amount.
Most insurance companies wear or require.
I'm sorry, require, I apologize. But Medicare states that a patient is compliant if they wear their CPAP mask for at least 4 hours per day, at least 70% of the nights of the week.
Does it have to be at night?
It has to be when you sleep.
When you sleep.
So,
Okay.
yeah.
So it does
So
have to be
most
when you
people
sleep.
sleep at night, but there are those who sleep during the day if you're a shift worker or such. But that is what Medicare's guidelines are.
Now,
If-
tell us how they monitor the smart card.
The smart cards are very, very nice, because it used to be in the olden days, you'd have to bring your machine back. There would be like an hourly counter that the person would have to double check, document that way. Now everything's done remotely. There's little computer chips that are built right into the CPAP machines, and the durable medical equipment company just punches in a code into their computer, and it dials directly into that machine, and they can tell their hours.
So if you're cheating, you can't get away with it.
And you can't cheat either, because the machines also know if the machine is just turned on and open to room air. It needs to sense that back pressure. And even if you plug it up against something, it needs to sense breaths. So the machines are very smart. There's really no way to cheat it now.
Okay.
So you can't put it on
10 years
sale.
ago, yeah, 10
Really?
years ago
Yeah.
you might have been able to, but not anymore. So, and really that's for the betterment of the patient. And patients are very educated today, and they ask a lot of very pertinent questions, and we're always happy to answer those questions. People are taking more responsibility for their health care, and they want to know, do I have to be on this 5 days a week or 7 days a week? And we always recommend that a patient wears it every day. If they're not wearing it, they're not getting the benefit from it.
I find it amazing because people will complain about how, cumbersome it is, but I have never met somebody when I say, how beneficial was it? Oh, it's amazing. I feel so much
Right.
better. It makes such a difference.
Right.
So it obviously is a key component
Right.
to solving this problem. Let's look at the
Full face
Full
mask?
the full face mask.
Okay.
And you have to tell us too, when do we need this monstrosity, we'll call it? Because these other two are so nice and light.
Well, people benefit from different styles of masks, and some people look at a full face mask and say, wow, that is really big, I will never be able to wear that. But it actually has some very nice features to it. Whenever somebody falls into REM sleep, Dr. Lileas was talking before how all the muscles in the bodies relax. And sometimes your jaw will actually drop open as well. So this needs to have a closed system. So if you're wearing a nasal mask and your mouth opens up, the air pressure is going to take the path of least resistance and come right out of your mouth. And then you're not going to get your therapeutic pressure. With a full face mask, even if your jaw opens up a little bit, it's still covered. This is still one closed system, and you're able to breathe through your nose or your mouth. Or, for example, people who have a deviated septum. They would not be able to wear a nasal mask because they can't breathe efficiently through their nose. So they would need to have something that covers their nose and their mouth so that they would be able to breathe through their mouth. It's more cumbersome, and you have to seal completely below the lip and up on the bridge of the nose, but it's absolutely able to be done, and The durable medical equipment companies and the sleep techs are very proficient at finding what mask is going to work the best. The other nice thing about coming in and having the in-lab sleep study is that we can try all the different styles of masks on the patient. We can tell you the pros and cons of each style of mask and then let you try it out for a while. And then if you decide, at 2 o'clock in the morning, I really don't like this full face mask, can I try the nasal pillows? Well, sure you can. Absolutely. We can switch that mask very easily for you.
That's fantastic. I want to talk about now, because some of the sleep disorders that Dr. Lileas is educating you on that are called parasomnias, and a few of these words I can't even pronounce. I practiced before, but I'm going to turn it over to you because you always want to sound intelligent. But if I have this mask on and I'm just starting to treat some of these, what do we do with the mask? So let's talk a little bit about enuresis.
Okay. Enuresis is the bedwetting.
And children. Let's touch on
yes.
this one with kids a little bit too.
Mostly,
how do we treat kids?
Mostly children, okay? Up until the age of 5, kids can have bedwetting. It's normal. We call it normal, but it happens. Mm-hmm. It's after the age of 5 or 6 years old that we start seeing as enuresis becomes a condition, something we need to possibly do something about, find out why it's happening. Is the kid having nightmares? One of the things that you think about in kids is, do they have obstructive sleep apnea? Mm-hmm. And is that what's causing them? Because they can't, they're waking up constantly, they're short of breath, and then when they do go to sleep, they don't even feel themselves going. So that's one of the things that you think about in kids that...
Can you put a mask on a child?
Absolutely.
Yes, you can. There's special circumstances for children with obstructive sleep apnea. They have to be tested much more frequently, and they have to have their masks changed at least every 6 months to a different style of mask, because their bones aren't fully formed yet, and you don't want to cause any permanent deformation of their bones.
And I'm assuming that's something a child can grow out of.
Depending upon what the cause is, absolutely. Mm-hmm. Really, the most common cause of sleep apnea in kids, tonsils.
So they usually try a surgical procedure first with the child.
Get the tonsils out, check them again, they're probably gone.
Right.
Interesting. Sleep terrors.
Sleep terrors are a parasomnia in which the child, it can be anywhere from 2 years old to 7 years old. You can see it older than that, you can see it maybe a little bit younger than that, but usually anywhere from, say, 2 to 7 years old. More commonly, 5 to 7 year old range. Kids wake up and they're sweating, they're screaming, they're staring at the wall. They may stand beside the bed. They may look like they're staring right at you, but they have no idea you're there. Mm-hmm. And it may last a few minutes. They calm down, get back in bed. They don't have any recollection of that at all in the morning. And that's a little bit different than kids that have the nightmares. That's also considered a parasomnia. The nightmares occur usually in the later part of the night during REM sleep. The sleep terrors usually occur like in stage 3 sleep earlier in the night. The difference between the nightmares is the kids remember that. Well, yeah, there was a big monster coming at me and it was trying to get me. Sleep terrors, they have no idea anything happened. But when you see someone that's had that, the look of fear in their face is unbelievable. You won't forget it.
And they're probably telling mommy and daddy and something's wrong.
And they're trying to, but they can't. Those are the kids who maybe down the road, 3-4 years down the road, can develop sleepwalking.
And you have a lovely name for sleepwalking.
Somnambulism.
Yes.
Yes, ambulating, or som refers to sleep, ambulism refers to walking.
And it's a real thing.
Oh, yes. Mm-hmm. Yes. My
Awesome.
oldest daughter had that.
And how did she do with it?
Absolutely. And it was very interesting to watch her growing up. She also had the night terrors. And, when we first saw that, we were like, what the heck is that?
Yeah.
And, and they didn't know, they didn't say a lot about it back then. This is, 20-some years ago. And no one said anything about it. They didn't there was no way to treat it, and there still is no way to treat it. It's just reassurance.
Now, let me ask you, because, and it's interesting, she's the one who is the yoga instructor and probably lives one of the healthiest lifestyles that a
Absolutely.
person can live. Has this gone away? The whole
She
problem?
she's not had any sleepwalking or sleep terrors.
So a healthy lifestyle does contribute.
Most sleep terrors go away on their own within a couple years.
Okay.
The sleepwalking can last for years.
What about, I love sleep talking, which is called,
Somniloquy.
yes, and sleep eating. People actually go and eat and don't even know?
There's two different types
Right.
of sleep eating. One is where people get up, they're actually trying to fall asleep, and they can't fall asleep, so they go down and eat.
But they know what they're
binge eat.
doing.
They know what they're doing. The other type is they have no idea what they're doing. They wake up, they go to the refrigerator or the freezers, pick out meats that may or may not be cooked, and try to eat them.
Oh, you are kidding.
Oh, no. No. Those are people that often will get sick the
Yeah.
next morning because they ate some raw meat or they ate, something that nobody should eat.
Oh,
So
my.
those are, unfortunately, those are rare disorders.
So if you wake up and find the refrigerator not in the same condition as when you went to bed that evening, you may be thinking about,
Might
hey,
be thinking about the sleep
Yeah.
disorder.
what did I do? I love the next one. Sexsomnia.
Yes. Unfortunately, with sexsomnia or sleep sex, it's oftentimes people who have been abused, or maybe a woman who's been raped, and they'll relive that during sleep.
Mhm.
And it's very, very unfortunate and tragic circumstances that these usually occur.
Well, then it is a very sad thing.
Yes.
Something I have, and I do sleep with the bite plate. Bruxism.
Mhm.
Can I have bruxism, sleep with the bite plate, and if necessary, also put on a CPAP mask?
You can. Sometimes whenever people use mouth guards, it does make it more challenging for a mask fit. But we absolutely work with people with mouth guards all the time, and we are able to help them. There's also, if you have mild sleep apnea or snoring, they also have oral appliance therapy that will kind of work in two fashions. It will help with the sleep apnea by pulling the jaw forward, and it works as that bite block so that you don't grind your teeth also. So if you would have mild sleep apnea, instead of using a CPAP mask in addition to a bite block, then they might recommend that you just try that oral appliance therapy and do it that way. But if you definitely need the CPAP, we do work with that. There might be a few other devices that we would have to use to help to keep your mouth closed, like a chin strap or something like that, but we definitely would work with you.
Anything else you would like to share before we close to things that you see frequently, hesitations people might have? Anything else you can really tell them that can help them to think about or consider, maybe I should think about a sleep study?
Well, I think the biggest thing is, what types of problems or complaints do people have when they have obstructive sleep apnea? And most of the ones that we see, patients have excessive daytime sleepiness. During the day, they could fall asleep anywhere. I'll be watching TV and I'll just, boom, down. I'm reading a book, boom, down. So people with excessive daytime sleepiness, snoring, neck size over 17 inches, obesity where the BMI is over 30 especially, those people have high risk factors, and there are high risk for obstructive sleep apnea. Those are the ones we kind of target and we're trying to look for to get them treated before they develop hypertension, before they develop heart disease, before they develop strokes. So that's what we're looking at. We have questionnaires that are available. I think you can actually get them online, right?
You
The
can.
Epworth.
The Epworth and the Berlin are
There's
both
something called the
available online.
Epworth Sleepiness Scale, which tells you your propensity to fall asleep. And it kind of helps us to, if we see someone whose Epworth scale is 15, that tells us that they could fall asleep in almost any situation. And we really want to study those people.
That's a little too much sleep.
Yeah.
Sheila, anything, if people want to contact you and they have questions, the number for the Delta Sleep.
The number for the
Lab.
Delta Sleep Lab, 330-729-9480. That's our Bourbon location. For our Austintown location, 330-270-3950. What I would like to say is people should not be afraid to speak to their physician about if they're not sleeping well at night. The physicians are there to help. Sleep studies are, especially at our lab, we do a really nice job of trying to make patients feel comfortable. Everything is private. You have your own private bedroom, private bathroom. We take our time and explain everything to patients, and you shouldn't be afraid to speak to your doctor or ask questions about your sleep. And you know, if you have any questions specifically about sleep, we would be happy to answer those questions.
And quickly too, if I decide if I do end up doing a sleep study, what time do I arrive usually? What time do I get to go home? I'm assuming it wouldn't interfere with the work week. Do you do it 6 days a week, 5 days a week, 7 days a week?
We actually will do it whenever your normal sleep schedule is. We schedule 7 days a week around a person's normal sleep time. So say, for example, you work midnights and you don't get home until 7 o'clock in the morning. We would do a study during the day. If you work 3 to 11 and you don't go to bed till 1 o'clock in the morning, then we would arrange our schedule around that, and we would have a technician start the study and then another one finish the study, so that it would be most convenient and most like your normal sleep patterns. Because that's very important. We don't want you working midnights and then have to come in at night, because that's not when you're going to sleep. We want to see what you normally do at home so that we can help you.
Oh, that's a great point. Great point.
Right, because if you work at midnight and then
Yeah.
you come in at midnight to, you're
You
not
won't
going to
fall
sleep.
asleep. That's your wake time.
And in your profession is probably the biggest offender during the, education and, internship and residency
Right.
and fellowship
Call
process
years.
and so on. Yes. And, you talked about when the body was originally made, it was designed to sleep correctly when it's
Sleep
dark
during the
outside.
day. Right?
No,
I mean,
sleep at
sorry.
night.
Sleep
I
at
know what you
night
meant.
and be awake during the day.
And then we even touched a little bit upon if you live in a climate, or like if you're in Alaska where you could have sunshine. You have daylight 6 months and you have darkness for 6 months sometimes, a slight exaggeration, but I mean, the body has to really adapt to something that it wasn't naturally
Right.
trained to do. So I thank you both so much for joining me. I really think it was a really enlightening and important, show. And Dr. Lileas, congratulations again. Pretty soon we're going to need an extra 15 minutes just to read your credentials. But we're so proud to be able to have access to you. Sheila, thank you so much. And to our viewers, I hope you enjoyed the show. I'm Mary Pepino, and thanks for watching Fit for You.